Today we're going to talk about the management of chronic pain in an older adult. My name is Tatyana Gurvich. I'm a clinical geriatric pharmacist. I'm an assistant professor of clinical pharmacy at USC School of Pharmacy, where I teach geriatric pharmacology at all levels of pharmacy school training. I'm also an adjunct assistant professor of family medicine and geriatrics at UCI Senior Health Center, where I am embedded in a primary care geriatrics clinic, and that's my main practice site where I see geriatric patients daily. We do assessments, we also do consultations and improve patient care from a pharmacologic standpoint.
So before we get into the opioid crisis and how we got into this problem to begin with, I wanted to give you a little bit of a historical perspective on how we got here. So when you go back to the late 1940s, we had a lot of World War II veterans coming back from the war with war injuries that were painful. And there was an anesthesiologist by the name of John Bonica, who actually is considered to be the father of pain medicine in this country. He was seeing these patients and trying to manage their pain and was unsuccessful, and that was really frustrating for him. At the time, narcotics were used sparingly. People thought they were incredibly addicting, so we were trying to avoid using them. And none of the interventionalist kinds of things were developed at that point, so he was very limited in what he could offer these patients. So what he did was he reached across the aisle to different physicians, psychiatrists, neurologists, rheumatologists, and also consulted with psychologists and physical and occupational therapists, and developed these inpatient sort of one-stop clinics where patients would come in and see a bunch of different specialists, and they would all coordinate their care. They were very successful, and these one-stop clinics kind of spread all over the country, and they were doing great work. But then closer to the 1980s, insurance began to change, and these single entities stopped being covered by insurances. So patients had to go outside to go get occupational therapy, for example, or physical therapy, or a psychology appointment. And so these clinics kind of fell apart, and this overall holistic approach became less effective. Then come the 1990s, when pain really became the fifth vital sign. The slogan was that pain is whatever the patient says it is. The World Health Organization determined that it was a universal right to have your pain treated. And right around the same time, cancer pain management guidelines and terminal care pain management guidelines came out. And I think this is where the first mistake happened, because at that point, chronic back pain and chronic pain in general kind of got looped into those guidelines. So we decided that chronic pain needs to be treated the same way cancer pain is to be treated. And the way it was treated at the time was there were long-acting narcotics, and you would give that as baseline therapy, and you would use immediate acting, short-acting their counterparts for breakthrough pain. Around the same time, OxyContin hit the market, and there was a giant marketing campaign to promote that drug. MS-Contin was already available. Fentanyl was also already available, and those also began to be used more frequently. Then come the 2000s, where you see a huge influx in controlled substance prescriptions into the DEA, and the DEA kind of looks at it and thinks, okay, we know how we manage pain. Physicians know what they're doing, and they kind of looked the other way. They didn't think it was a concern. At the same time, JACO starts mandating that pain assessment and aggressive pain treatment is done in order to get facilities accredited. So there was a giant push to ask everybody how much pain they're in and really push for treatment. And then we come to 2010, 2015, the opioid crisis. So what's interesting about this slide is I think at this point, we're kind of going back to this multidisciplinary approach where physicians are partnering with other specialists to provide this overall holistic pain management.
The CDC guidelines for pain management are really targeting primary care providers because it was found that the majority of prescriptions are coming from primary care providers because they're in the forefront of managing these patients. Internal medicine, family medicine are the first physicians that these patients go to, and so there are more prescriptions coming out of those specialties. What's important to understand is all of these guidelines only apply to chronic pain management, such as back pain, fibromyalgia, and other kinds of chronic pain. They do not apply to cancer pain patients. So, and they don't apply to palliative care or end-of-life care. So if you have patients like that, you're actually more free to manage their pain aggressively with narcotics. We need to manage their pain enough so that their cancer pain is no longer an issue, or end of life kind of pain is no longer an issue. So when you see a complicated cancer patient with a strange combination of medications, that might be a good approach with that patient because that's what it takes to control their pain.
So what are the numbers behind the opioid crisis? They're pretty staggering. 20% of patients with chronic pain receive an opioid prescription from their primary care doctor when they leave the office. And there were 259 million prescriptions written in 2012. And that's enough for every adult in the United States to have a bottle of pills, which is a really frightening statistic, I think. In terms of misuse figures, they're equally frightening. 11 million Americans are misusing opioids currently. There are close to 500,000 deaths from overdoses from 1999 to 2017. If you look, this graph is interesting because if you look at when do you get in trouble when you start prescribing narcotics, it's actually pretty early in the treatment. So the risk of continued opioid use increases past day 3 of a prescription. So that's one of the reasons why when you prescribe opioids for acute pain, you really want to limit the script for 3 days or less, because when you get to 5 or more days, the incidence of continued use really increases, especially during the first year. So with all these scary numbers out there, are we getting any better at managing this problem? Because we've been in this opioid crisis for the last couple of years. And the answer is yes, we are getting better. We sort of peaked with prescriptions in 2012, giving out 255 million of them. By 2017, we were down to 191. So we're definitely improving. And we're also improving in prescribing fewer high-dose prescriptions, which is also promising. So what about the opioid crisis in seniors? They're really kind of in the same boat. Over 500,000 seniors received opioids in doses higher than the recommended by the manufacturer in 2016. And the number of older adults who misuse opioids is expected to double by next year. While we're talking about the opioid crisis, we're also looking at our patient population. And pain is a much more common symptom that patients are complaining about now than they did, say, 50 years ago. If you look across the ages, more patients are in pain. And for most of those patients, it's lasting more than 3 months. So for both younger adults and older adults, when you look at the older patient population, they've got more advanced disease. So they have issues like more advanced arthritis, fibromyalgia, neuropathic pain, all kinds of chronic back pain issues and musculoskeletal problems. What are some of the geriatric specific considerations? Older adults are at increased risk for confusion and mental status changes as a result of treatment. They're also there's an increased fall risk, and all of the medications you're going to use for pain increase that risk further. They've got pre-existing respiratory disease, and so they're more likely to get respiratory depression when you use these narcotics. They've also got reduced renal function, and so you have to constantly adjust doses to accommodate for that. The other important points are, these patients are on a lot of meds. There's a giant risk for drug-drug interactions, adverse reactions, and simple medication errors because there's so many medications for them to deal with. Sometimes these patients get into these overdose situations completely innocently because they've mixed up their regimen somehow. The other point to point out is that they're at much higher risk for elder abuse when you're dealing with these narcotics being prescribed on a regular basis, and we'll get into that a little bit more later. When you look at the 2019 Beers criteria, they're also concerned with the use of opioids, and they're telling us to avoid using them in patients with a history of falls or fractures because they're an increased risk for syncope, retarded psychomotor function, and additional falls. And a lot of our patients are falling when they're older, so that's a really common thing we have to deal with. So do we not give opioids to anyone who's fallen? That's probably an overstatement, but we do have to kind of keep all of that in mind when we're deciding what to prescribe and how much to prescribe. The Beers criteria is also telling us if you're using opioids in combination with other psychoactive medications, you're also putting the patient at risk for falling and an increased risk for overdose. And so what the goal should be is to use no more than 2 additional psychoactive meds in addition to the opioids. Otherwise, we're increasing the risk of falling. And so that really creates a problem because we're supposed to use adjuvants. They're psychoactive drugs. When you combine them with opioids, you're going to increase the risk of falling and psychomotor retardation and all of that. And so it really puts us in a bind. What do we do? And I think the key is to kind of start low, go slow, and gradually and carefully. So let's look at the adjuvants and the Beers criteria. All the adjuvants are on the Beers list. All Nsaids that we're supposed to use as adjuvants are on the Beers list due to GI and cardiovascular risk. You want to avoid Nsaids in patients with symptomatic CHF and use them very cautiously in patients with asymptomatic CHF. And there are other risk factors as well. Every time you put somebody on an Nsaid, there's an increased risk for blood pressure going up. If patients take Nsaids on a PRN basis, you often will find their blood pressure fluctuating depending on when they took their last Nsaid. There's also the risk of acute kidney injury, so you're always wanting to monitor the creatinine. There's also an increased risk for GI bleeding, especially in those patients over the age of 75 on prolonged regimen of Nsaids. A lot of these patients are also on antiplatelet medications, periodic steroid bursts, maybe anticoagulants, so that also puts them at higher risk for bleeding. Indocin and Toradol are particularly isolated on the Beers list as Nsaids not to use. The reason is they're both at significantly higher risk for GI bleeding than the other Nsaids. Indocin also causes confusion in older patients, and Toradol can too because it's a mu and a serotonin reuptake inhibitor. What about the other adjuvants? Tricyclics are on the CDC guideline criteria for pain management. We do not want to use them in older patients because of all of their anticholinergic effects, orthostatic changes, excessive sedation. All the tricyclics are on that list. Amitriptyline is the worst of the tricyclics. Nortriptyline is a little bit better. Dizipramine is a little bit better. When you've got a patient with cognitive impairment and you're suspecting some kind of a memory decline or dementia, you do not want to use anything with an anticholinergic profile. Muscle relaxants are not necessarily that effective. The efficacy is really unclear, particularly at lower doses that you want to use in older patients. Some muscle relaxants are anticholinergic. They all increase the risk of dizziness and increase the risk of falls. SSRIs and SNRIs also pose risks in older patients. They're on the Beers list for an increased risk for falling and fractures as the result, and also hyponatremia, particularly at higher doses. So you want to kind of keep an eye on that sodium. You also want to be careful in patients with reduced renal function, especially less than 30 mils per minute, because that increases the risk of side effects. Gabapentin and pregabalin are good adjuvants to use, but again, I have to be super careful. Excessive sedation, dizziness, falls, and edema, especially as you go up the dosing ladder. And side effects are more likely with creatinine clearance of less than 60. So you have to dose adjust these medications. The CDC guidelines point us to using non-pharmacologic options first. So cognitive behavioral therapy is found to be very effective in managing their pain and managing the expectation of maybe necessarily being pain-free. It kind of allows you to look at your pain a little bit differently, avoiding catastrophic symptom thinking, and sort of working on the disability issues that are associated with pain. Also, exercise, integrative medicine that includes manipulation, massage, acupuncture has also been shown to reduce pain and improve things like osteoarthritis and fibromyalgia. And these two modalities in combination are supposed to be more effective than individually. So let's look at the selected adjuvant therapies. So I think the key here is start low, go slow, and kind of monitor closely. So Tylenol, I think Tylenol overall is probably underutilized. Patients take a pill here and there, it doesn't seem to work, and they stop. I think Tylenol is worth a fair shake, especially for mild to moderate pain. The maximum dose for an older adult is 3 grams. 2 grams if they have some kind of pre-existing liver disease or are drinking a little bit more than they should, and 3 for an otherwise healthy patient. So maximizing that Tylenol dose can be really helpful. When you're choosing an NSAID, it's really important to remember that they're all very individually effective and very individually tolerated. So it often requires a trial of 2 or 3 different ones before you find one that works and that they can tolerate. I've listed 4 here that are commonly used, but there are others as well. The one I don't have on the slide is Relafin or Nambumetone. That's a good NSAID to try also, and it appears to have a little bit less of an antiplatelet activity. In terms of the ones listed, again here, the key is low dose. You know, if you're using ibuprofen, the starting dose should be 200 milligrams once or twice a day maybe, and you go up slowly to maybe 400 3 times a day, provided they don't have a history of GI problems and their kidney function can allow for that. Again, naproxen, using over-the-counter doses, 220 milligrams twice a day is probably a good place to start. Meloxicam works really well. It's more COX-2 specific than some of the other non-specific NSAIDs. So again, a low dose, 7.5 milligrams daily to start with, and 15 max. Celecoxib can be used. It's a little bit more GI protective, but the renal insufficiency problem is still there, so you have to keep an eye on that creatinine. Again, lower doses are better. I think topical adjuvants are sorely underutilized, and sometimes they're used incorrectly. So one thing to keep in mind is lidocaine can be really helpful for kind of a localized pain where it's only in a couple of areas. Lidocaine is now available over the counter at 4%. It's available in all dosage formulations: patch, gel, cream, and you can apply it 3 times a day to sometimes multiple areas that hurt. It's also available prescription as a 5% ointment or patch. Since it's gone over the counter, insurances don't like to cover the prescription formulation, but it's sometimes they do, so it's something to keep in the back of your head. Diclofenac gel can be really effective at 2 to 4 grams 4 times a day. The basic problem I find with diclofenac is that people don't know how to use it. It comes with a ruler that's in the packaging, Yesterday, we saw a patient in one of our clinics, and they brought the Diclofenac Gel with them to show me that they've tried it and it doesn't work. I looked in the package, and the measuring stick that they're supposed to use every time was stuck to the upper packaging. So they didn't even know it was there. It does come with a measuring stick. It comes, it's a 2.5 inch ruler. For 2 grams, you're supposed to use 1.25 inches, and for 4 grams, you're supposed to use 2.5 inches. And you're supposed to actually measure it out on that stick, and that's quite a bit of medication. And if you apply that 4 times a day, that will be a lot more effective. There's also capsaicin cream, which is a hot pepper derivative, which sometimes helps. You have to be a little bit more careful with those with very delicate skin or who don't like the burning sensation it produces. But that can be helpful sometimes and kind of distracting from the actual pain you have by applying this cream. Camphor oil and menthol can be applied liberally. There's no maximum dose. It's well tolerated, and it's very popular with some segments of the population. Asian patients love this stuff. Eastern Europeans love this stuff. And if that's what works for them, they can use it as often as they like. More adjuvants. When you're talking about other adjuvants, we're talking about SNRIs, obviously, and things like Neurontin and Lyrica. They all have side effects. You know, with SNRIs, there's a worry with an increase in blood pressure, particularly with Effexor, less so with Cymbalta as you go up the dosing range. Cymbalta is more likely to cause drug-drug interactions. Effexor is a little bit less likely. They both are put the patient at risk for hyponatremia and fall risk at higher doses. So I think the trick here is to start with a low dose. So duloxetine, the lowest milligram it comes in is 20 milligrams, and that's what you should start with. And titrate up slowly to 60 milligrams daily. Venlafaxine, the lowest it comes in is 37.5, and that's the starting dose. You can do extended release or immediate release and gradually work up. Gabapentin and Neurontin, they also have side effects: sedation, dizziness, risk of falling, and edema. When we send our patients to pain management, they will often start gabapentin at 300 3 times a day. These patients will get dizzy and fall within a week, or be so sleepy that they can't really function. So again, I think the key is to start with lower doses to see how they tolerate it. So gabapentin should be started at 100 milligrams at bedtime, and you kind of stack the dose more at bedtime. So you go from 100 maybe to 200 to 300 at bedtime, and see how they do. And then maybe go to 600 at bedtime. And if then after that, if that's not enough, if you need to use it during the day, use lower dosages during the day and a higher dose at bedtime to avoid daytime sleepiness. And hopefully they'll sleep through most of the dizziness and during the night. Same thing with Lyrica. Again, low starting dose and gradual titration upward. These medications do have to be renally adjusted, so you have to keep an eye on the creatinine. What about cannabis? If you ask your patients whether they have tried cannabis or they've thought about trying cannabis, I think I would say at least a third to a half of your patients, the answer to that question would be yes. When you look at the data for cannabis for pain, it's actually really limited. Most of the data is in patients with neuropathic pain. It may be effective for neuropathic pain. When you look at the nice randomized controlled trials, what you find is the number of patients in those trials is very small, less than 100, usually 10 to maybe 70 patients max. Most of the time, they're using THC dominant products, and the majority of those patients are younger adults. There's very little information about safety and efficacy of cannabis in older patients. What we do know is that THC creates more of an adverse reaction profile that we don't want to use in older patients. There's an increased risk for confusion, delirium, psychosis when you use THC dominant strains. We do know that CBD does have some anti-inflammatory and also analgesic properties, so it may be helpful, but there's not a lot of data using CBD dominant products in patients with pain and in patients with pain who are older. There's also the issue of standardization and purity. It's really hard to say whether the product they're using in those randomized controlled clinical trials, are we going to be able to get the same product in the dispensaries? That may not be the case. If you do decide to recommend cannabis, what I would recommend is starting with CBD oil only, pure CBD oil. The dose for an average adult is 5 to 10 milligrams to start with. So an older adult, the dose should be reduced to 2.5 milligrams, going up to maybe 5 or 10 if they can tolerate it. If that's not effective, for an average adult, they do recommend adding a little bit of THC, tiny dose, 1 to 2.5 milligrams. But again, if you look at some of the formulations that I've seen that are coming out of dispensaries, they have a lot more CBD and THC in them. So I don't know that older adults, it would be appropriate to use these products in older patients. The approach with CBD, if you do use it, is start low and go very slowly. And again, adverse events you're worried about are things like falls, confusion, delirium, psychosis, and all that other stuff. The two references on this list are useful. The first one is just a commentary on the use of cannabis, and it does talk a little bit about the doses that are on the slide. And the second reference reviews all the well-done randomized controlled trials with cannabis and chronic pain. So you might want to look at that. The other big thing is patient education is really lacking in this area. When patients come to the doctor's offices, we don't know how to talk to them about cannabis. I think most of us are uncomfortable recommending it or not recommending it. And so their primary source of information is somebody in the dispensary, and their primary goal is to sell the product. So at this point, it's kind of not a good system.
So this is an opioid equivalency table. There are lots of them out there. This I found is a fairly accurate one that's sort of consistent with good practice standards. And it gives you ratios of one narcotic to another. So for example, codeine and tramadol are 10 times less potent than morphine. Everything is sort of compared to morphine. Morphine is the gold standard. So tramadol and codeine are less potent than morphine by about 10 times. Hydrocodone and morphine are about 1 to 1, so they're essentially equivalent. Oxycodone is a little bit stronger than morphine, about 1.5 to 1. And then of course, things like Dilaudid, fentanyl patch, and even oxymorphone are significantly more potent than morphine. There's also a link on this slide to the CDC opioid calculator, dosing calculator. So if you download it to your phones and you put in any narcotic that you have, it'll immediately convert that dose to morphine equivalents per day, which is really what we're trying to minimize. We're trying to give patients doses that are less than 50 morphine equivalents per day. It's been shown that doses above 50 increase the risk of overdose and potential adverse events. And we definitely want to not use more doses that are higher than 90 morphine equivalents per day. So 50 is really the first trigger number, and 90 is the second trigger number that we really want to stay away from. So if you're using more than 50 morphine equivalents a day, you really have to justify that this is a regimen that's effective, that it's working, and all the precautions for overdose have been discussed with the patient. What about tramadol? Tramadol is sort of a funky narcotic. It's a combination of a weak mu agonist, so a weak morphine, and it's a serotonin and norepinephrine inhibitor, so it acts a little bit like a Prozac or an Effexor. So it's got a little bit of an antidepressant effect and a little bit of the morphine kind of effect. You get side effects with this drug from both of those sides. So just like an antidepressant, you will get symptoms of hyponatremia. You'll also get, there's an increased risk for seizures. You have to dose adjust this medication in patients whose kidneys aren't working well and their creatinine clearance is less than 30 mils per minute. And you do get more CNS effects in patients with poor kidney function. There's also a risk for serotonin syndrome. Again, because tramadol is a little bit like an antidepressant, when you're dealing with some tramadol, a little trazodone for sleep, maybe another antidepressant that the patient is taking for anxiety or depression, all those drugs together, even at low doses, can cumulatively cause serotonin syndrome. And traditionally, tramadol has been considered to be the safer option because it doesn't bind the mu receptor as strongly as some of the other narcotics. But there was this article in JAMA in March 2019 that came out of England that showed that there was an all-cause mortality increase when patients are taking tramadol versus traditional Nsaids long-term. So this was a study out of England. They looked at 11.1 million patients with osteoarthritis of the knee, hip, or hand from many different practices in the UK over a 15-year period. And they found that using tramadol was a little bit more dangerous than using chronic Nsaids, as you might expect. And the difference between, there really was no difference between using tramadol and something like codeine.
Here's a comparison of tramadol with several commonly used Nsaids that they tried, and clearly tramadol causes, puts patients at higher risk for all-cause mortality. There's not much difference between codeine and tramadol. So I don't know if it makes a difference. I mean, I don't think it makes sense to use codeine instead of tramadol. I think they're both equally bad. Methadone. Methadone is now not recommended per the CDC because it's associated with a disproportionate number of overdoses relative to prescribing frequency. I think that may be kind of a fuzzy statistic because a lot of methadone is used in heroin rehab, and patients are on methadone to get off whatever drug they were using prior to that. So that's a high risk population to begin with. But the other issue is it does cause QT prolongation. So if you use it, you have to get an EKG and make sure there's no QT prolongation there. The thing is, though, methadone is the only naturally long-acting opioid. A lot of the overdoses we saw, especially in the beginning when OxyContin hit the market, is patients would change the formulation. They would crush the pill, crush the extended release formulation, and it would release all this drug all at once. They would take it and overdose. You could do the same thing with MS-Contin. You could do the same thing with fentanyl. Drug addicts would often rip up the patch, pull out the liquid, and inject a 72-hour dose all at once. So that will obviously cause an overdose. But with methadone, you can't do anything to it. You can boil it, you can pulverize it, you can crush it, you can do whatever, and it'll still have an 8-hour half-life. So that was the nice thing about methadone. It could actually be used long-term in a carefully screened patient and get pretty good results. The other big thing with methadone is that the conversion ratios are dose dependent. So you had to know how to dose it safely. And this is an article that was published a while ago, but it's a really nice methadone conversion table of how to do it if you have to. And the conversion ratios really depend on the dose. Using long-acting opioids with short-acting narcotics. In general, the CDC guidelines do not recommend doing that routinely. But the reality is that you may have a really complicated pain patient every once in a while where that's necessary. These are the patients that have constant severe pain that's around the clock kind of pain, where you've tried adjuvants, they've gone to cognitive behavioral therapy, they've done PT, and they still have this severe pain. So in those patients, it may be appropriate to use a long-acting opioid with short-acting drug for breakthrough. If you do that, you have to know how to do it right. So typically a long-acting agent is a BID or a TID kind of a schedule. BID in the beginning, when they develop a tolerance to the dose, you sometimes have to go a little bit more often, TID. The patch, fentanyl patch, is a 72-hour patch normally. Again, if it's used for a long time, the efficacy will shrink to maybe 48 hours. So you have to reapply it a little bit more frequently. And if you have to use a short-acting breakthrough medication, you have to figure out the proportionate dose. So the breakthrough dose should be 10 to 20% of the total daily dose. So for example, if your MS Contin dose for this patient is like 30 milligrams twice a day, for example, that's 60 milligrams total. So the breakthrough dose should be 6 to 12 milligrams of morphine equivalents. And the breakthrough dose should not be given any more often than maybe 2 to 3 times in a 24-hour period. If you're using it more often than that, then you're really underdosing the sustained release formulation. When you're switching between narcotics, you really have to back off by at least 20%. Some people recommend even by as much as 50% and kind of gradually going up to a point of efficacy. The reason they don't recommend using this approach a lot is because there are a number of studies that show, like this one, for example, that show that there's an increased risk of mortality from using long-acting opioids indiscriminately. So they looked at patients using adjuvants versus long-acting opioids, and they found that using long-acting opioids really increased the risk of overall mortality and out-of-hospital deaths, especially in the first 180 days of prescribing long-acting opioids. This particular study actually didn't include the very old, so I think if you did, maybe those numbers would even be greater. So you do have to be careful. We can't just give everybody long-acting and short-acting drugs on top of that. So how do you prescribe opioids safely in older patients? You want to start with 1/4 to 1/2 of a regular dose, and you want to use immediate release option first, not extended. And you really want to limit that initial therapy to 3 days or less. Because again, when you get beyond the 3 days on the initial prescription, you're really increasing the risk of patients continuing to use opioids. You want to reassess frequently, 1 to 4 weeks. In your chronic pain patients who are already on a regimen, at least every 3 months. Some clinics are requiring you to come in once a month to check in. So 3 months is a very liberal kind of a window. You want to keep doses as low as possible and usually below the 50 morphine equivalents per day, because again, above that amount, you're really putting the patient at risk for overdose and problems. And you always want to avoid doses over 90 morphine equivalents, if at all possible. When you're titrating patients off, you want to also do it very gradually. The slower you do it, the more successful the titration will be. And you want to reduce the dose by 10% at a time, maybe bring them back every month to reassess and lower a little bit more. And once you get to the lowest possible dose, you extend the dosing interval. Some risks associated with opioid use. They're listed here. It's a pretty busy slide. I just want to point out a few things that are more of an issue with older patients. Again, confusion is a big one. Urinary difficulties. A lot of them will have urinary retention already from maybe BPH or other factors. This will cause more of a urinary retention picture and sometimes will cause overflow incontinence as a result. I often bring up sexual difficulties in men and women, and sometimes when I talk about that with patients, they're more reluctant to use these medications because sometimes they really hold on to that um, ability to enjoy sex. Um, the other thing you want to point out to patients is the concept of hyperalgesia. It's basically an increased sensitivity to pain when you've been on opioids for a long time. So you could have a patient who's been on chronic pain management for a long time, but they seem to be in more and more pain. You know, they stub a toe and they're screaming of 10 out of 10 pain, where a non-opioid patient might sort of stub a toe and keep walking. So when you see that picture of patients complaining of more pain despite using more medication, that's when you really have to sit down and talk to them about hyperalgesia. And that's probably the time when you want to kind of back off on the dose, which sometimes makes symptoms better. It sometimes creates less pain when you back off on the dose. The other big thing is victimization. Opioids are strongly associated with elder abuse. Opioids can be used sort of to withhold pain management while you're asking an older adult to write you a large check for something. They could be overused in an older patient where they're just sort of knocked out and out of it during the day so that the caregiver can do whatever they want during the day and not really take care of the patient. Medications like this get stolen from patients and they're used on the black market for more money. So there's a lot of elder abuse kinds of issues around the use of opioids, and that should be seriously looked at with every patient. Risk factors for opioid overdose. Who's at risk for it? Anytime you have a patient with a history of substance abuse, anytime you have a history of some kind of depression, anxiety, psychiatric kind of disorder, anytime you're at higher doses, again, 50 morphine equivalents per day or higher. Methadone use is also an increased risk. Combination of drugs, especially with benzodiazepine co-prescribing. When you have somebody with a benzo and a narcotic, you absolutely have to use naloxone. You have to give them naloxone as a precaution. But also when you're using a bunch of things in combination, like antidepressants, benzodiazepines, and opioids. When you've got somebody who's never been on an opioid before, you're giving it for the first time, that's actually, you're putting the patient at risk for an overdose right away if the dose you're giving is higher. So that's also a risk factor. Patients who are in an abstinence program, obviously, that would put them at risk. Sleep apnea and heart and pulmonary complications are also risk factors. Tools for prescribing opioids. I think the most important thing is to set goals for the patient. So you have to have a conversation of how much pain relief are you expecting and how much function can you expect from the pain relief you get. I think a lot of patients' goals sometimes are unrealistic, and we have to sort of set parameters around that to make sure that they understand that with this pain relief, this is how much you may be able to do. You may not be able to do everything you want to do, and that's okay, provided you make adjustments in your daily routine or schedule. You have to have a plan in place for stopping opioids if the treatment is ineffective. It's not going to be effective in everybody. Opioids do not work every time you give it for pain, and patients need to understand that, and there has to be a plan in place to discontinue it safely. And you want to evaluate the patient every time you see them to make sure that there's meaningful improvement in both pain and function. If they're getting pain relief, but they're still not able to do the things they want to do, that's not good treatment. So you have to kind of revisit it periodically. The other pieces that can be helpful is a pain contract. A pain contract should be signed by every patient on opioids. We do it at UCI. Lots of institutions now provide that as part of their opioid treatment. And in the pain contract, you're discussing risks of opioid therapy, benefits, things to watch out for. You're sort of setting parameters with which you're willing to prescribe these medications. No early refills, no lost or stolen prescriptions. Sometimes you ask patients to fill out a pain diary to see how effective it is. Sometimes pain diaries are really effective because patients really use them appropriately. Sometimes you get them and you can see that it was all filled out the night before with the same ink, same handwriting. It doesn't look legitimate. But if the patient is really after getting their pain taken care of, a pain diary can be really helpful because it can tell you how quickly the medication started working, how long it lasted, what they were able to do while being pain-free. So it gives you a lot of good information. You're also looking for red flag behaviors, which I'll go over in a few minutes, of things that could be a concern with patients. You want to run a cures report. The recommendation now is every 4 months, but really I think you should be running it every month. And sometimes cures reports can be really telling. You may only be prescribing an opioid to that patient, but somebody else may be prescribing an SSRI and some patients, start over. The cures report is a really good idea to do. Obviously, it's required to be done every 4 months, but you should really do it more often because what it'll tell you is what other physicians are prescribing that you may not be prescribing. So you could be prescribing narcotics only, but somebody else may be prescribing that benzo, or somebody else obviously may be prescribing another narcotic. So it gives you a better picture of what's really going on. Urine drug testing is also really helpful. And sometimes physicians have a problem with that because they think, I've established trust with my patient. They think I trust them. The patient trusts me. And by my checking their urine every time, that really puts sort of a bad spin on our relationship. I think the way to approach it is from a safety perspective. What we found when we started doing drug testing in patients is that a lot of times these tests come back negative. So we're giving that Norco number 90 every month, or 60 every month, or Tramadol 120 every month. And the patient, when you do a urine drug screen, it's negative. So they're clearly not using it enough. So when you randomly test, it's positive. So that's the issue. So, and that becomes a safety issue. If you're positive and you're supposed to be positive, great, we're on the same track. If you're negative and I'm giving you all these narcotics every month, that's not safe for you. What if you take too many? What if, that's a real risk for overdose right there. And then obviously naloxone use should be used appropriately in those patients. So a team approach can really be helpful. Psychologists, social workers, they can help with the pain contract, discussing the pain contract, discussing the risks, discussing the benefits, and introducing cognitive behavioral therapy as part of the treatment. Physical and occupational therapy needs to be consulted. First of all, physical therapy can really help with strength training, which can also relieve pain. And occupational therapy can be really helpful in kind of structuring your daily routine so that you're able to work around the times when you're in more pain. Somebody like myself can really hone in on the drugs. I can tell you, when I interview the patient, all I talk about is medications. So I find out what's worked for them, what's not worked for them, how often are they actually using those adjuvants, how often are they using the PRNs. I get a 24-hour recall on how they use the narcotics and whether or not they work. Before coming to USC, I spent about 20 years teaching in a family practice residency program at Glendale Adventist. And there, we had a pain management team. We basically had a pain management clinic with a social worker, myself, and a couple of attending physicians who were willing to help us. And we would get these chronic pain patients that nobody wanted to see in clinic. We would do a thorough med review. The social worker would go over the opioid risk assessments with the patient. We would go over the pain contract and sort of set up boundaries for continued management and refill process. And it was really helpful. We did this before the CDC guidelines hit. We did this in the early 2000s when we're getting a lot of pain patients in our clinic on Norcos, on Dilaudid, on OxyContins, and the residents and some of the attendings even didn't know what to do with them. They would send them to pain management and they would come back with notes like, okay, prescribe narcotics per PCP. And so that wasn't helpful. So they would come to us and we would do this overall assessment, tighten up the adjuvants, most of the time reduce the narcotics and send them back. So this team approach can be really helpful in managing patients' pain. So what are some of the red flag behaviors? Patients who are drug seeking are really bad historians. When I ask them about their 24-hour recall, it's really difficult for them to tell me when the first dose of the narcotic was, how quickly it started working, how long did the pain relief last. They're always giving you circular answers. Then they get really frustrated with you and sometimes even call you names. Sometimes they start saying, well, this is incompetence. I don't need to tell you this. So they get very angry and belligerent for no reason. All I'm asking are very sort of direct questions. When you took that Norco, how quickly did it work? How long did it last? And they can't tell you that. They have difficulty describing exactly where it hurts. It's kind of pain all over and they can't quantify it. They can't give you a quality to it. There are a lot of level of function inconsistencies. So you're giving them all these narcotics, but they can't do anything. Or you're giving them these narcotics and they say they can't do anything, but they look like they're able to move and function pretty well. So there are a lot of inconsistencies in the picture you see and what they tell you. They're not able to tell you what they've tried before and what has or has not worked. Every time you bring up an adjuvant, oh yeah, I've tried that. Oh yeah, I've tried that. I've tried everything. And nothing seems to work. They don't remember doses with which you've tried them. It's a very confusing picture. They lose prescriptions. Prescriptions get stolen. They're constantly requesting early refills. They go off on many tangents when you ask a very specific question. So all those things are kind of red flag behaviors that might point you to the fact that this patient may be drug seeking. Drug screening is a good idea. The thing to remember is that these drugs kind of stay in the urine for a couple of days. So if you get a negative drug screen, that should tell you that they haven't taken these medications for several days. At-risk patients indicated for naloxone. So obviously high-dose opioids require naloxone prescription. When you're switching from one opioid to another, that might be a time to give a naloxone. Patients with reduced renal function, obviously severe COPD, patients on combinations of drugs. Sometimes patients requested just to have it at home for safety. Sometimes if a patient lives remotely and it can't easily access emergency services, that might be a reason to give naloxone. And obviously if they're on methadone or buprenorphine, they should be using naloxone.
So this is the slide that describes how you might use naloxone and what options we have with this medication. So obviously we have the vial option that's primarily available in the inpatient setting. We have the nasal spray and the auto injector. So the two formulations that patients might use in the community would be the auto injector and the nasal spray. The auto injector works very similarly to like an EpiPen, but it's extremely expensive, and at least currently it's very difficult to get this prescription through insurance, and it literally costs thousands of dollars. So the most common form that we would prescribe patients to have on hand in case of an emergency in the community would be the nasal spray. They come in a package of 2 cartridges, and you might just use one if the patient wakes up after the first administration in the first nostril. You're done. If there's no reaction after you administer the first cartridge, in about 2 to 3 minutes, you might want to re-administer the second device. And then obviously whenever you administer naloxone, you call 911.
Because we're in this opioid crisis mode, there are a bunch of government agencies that are working very hard to improve the situation. So you've got a lot of research going on in the area of pain management and how to avoid narcotics altogether. The FDA is requiring more sophisticated packaging of these formulations so they're not easily disrupted, which could potentially cause an overdose. You've got a lot of opioid recovery centers that are being funded to deal with opioid addiction, things like that. So this went into effect in 2018, and you're supposed to do it every 4 months, but I really, to be safe, I think it should be done every time you're refilling a prescription. The way we've dealt with the opioid crisis has really created a lot of anxiety for patients. So when they do get that prescription for you, they go to the pharmacy and try to get it filled, and they can't fill it. Insurance plans only cover a 7-day supply. Anything beyond that requires a PA. So the pharmacy will punt the prescription back to you to do a PA for it. If it's a Schedule II prescription, what they will do is they'll give a patient a 7-day supply. The rest of the quantity in that prescription becomes null and void, so you have to rewrite the prescription again. If it's a Schedule III prescription, they'll keep that quantity on file until the PA comes through, but it still requires a lot of back and forth between the doctor's offices, the pharmacies, and patients often have to go to the pharmacy a bunch of times to get their prescriptions filled. A lot of times diagnosis codes are now required, so I think it's a really good idea when you write a narcotics prescription to put a diagnosis code on the prescription already, so that that's not something that they stop the filling process for. They often want to know if the patient is also managed by pain management. So if they are, that's a good thing to put on a prescription also. And some pharmacies have instituted this ridiculous practice of if the patient isn't filling the prescriptions, exactly on a 30-day schedule, they don't consider it chronic pain, so they won't refill them. We have actually a couple of cases where the Tramadol prescription came up for renewal. We looked in the chart, the patient was actually in the hospital at that point, and we decided to hold off on refilling because we weren't sure what the regimen is going to be when the patient comes out. Well, when the patient came out and went to pick up a prescription, they wouldn't fill it because it's been more than 30 days since the last prescription was filled. So they decided it wasn't chronic pain management anymore because there was a gap in treatment. So those are the kinds of things that are happening now, which are kind of irrational and need to be fixed. So since the 2016 initial guideline, there's been an update. And this is a really interesting commentary that was published in the New England Journal of Medicine in June of this year, talking about the misinterpretation of the CDC guidelines. We've been really inflexible in the interpretation of dosages, treatment duration limits, and a lot of patients have been inappropriately, quickly tapered off their narcotics when that should not have been done. Some patients still need these narcotics. They're really complicated patient, like sickle cell patients potentially could be in a lot of pain, and they have to be managed very differently than your average chronic pain patient. So the application of the guidelines ended up on the wrong patients. A lot of cancer patients got tapered off their narcotics, and that was a giant problem, obviously. And these guidelines were not meant to address patients who were already on high doses. Presumably, they were on high doses for a good reason, and they probably needed to continue to stay on those meds. So we kind of panicked and took everybody off everything, and now we're sort of backtracking and figuring out how to do it right. There's also been a bunch of lawsuits that have recently settled or have been in the paper of billions of dollars that insurance or the pharmaceutical companies are paying out to states because they've misrepresented the drugs. I mean, I think it's nice that we found a responsible party for this, but on the other hand, if these pharmaceutical companies are going to spend all of their money in reparation, where is the drug research going to come from? You know, we need safer pain alternatives to be provided for these patients. And if the companies are busy paying out lawsuits, I'm afraid that they're going to have less money for research and development. So that's just something that's sort of a conversation piece, I guess. So here's a case that, this is an actual case that was one of my students witnessed on one of her rotations. This patient came from a South Bay hospital. So a 78-year-old female who was brought in by ambulance for a suspected overdose. Past medical history was relevant for major depressive disorder, chronic pain, benzodiazepine dependence, opioid dependence, and mild dementia. So this is a little cocktail of disaster when you look at this kind of patient. Social history, she lives alone, another red flag. She doesn't let other people help her with her meds, a huge red flag. And previous history shows past overdose situation. When you look at the presentation, she was positive for benzodiazepine and opioid use on urine drug screen. She was hypoxic on admission and gradually improved. Her renal function is great, so that's something to keep in mind when we're going to do medication adjustments. This is her med list. Look at this strikingly long psychoactive med list. She's on clonazepam, long-acting benzodiazepine, not indicated for someone with dementia. She's on donepezil for memory. She's on a high dose of Lexapro, which is probably too high for someone her age. She's on hydroxyzine 10 milligrams, which is an anticholinergic antihistamine and should not be used in patients with dementia. She's on a relatively low dose of a narcotic. Look, she's on Percocet 5-325, that's 15 milligrams in 24 hours. That's the equivalent of about 20 morphine dose equivalents, so not a large dose. She's on a high dose of pregabalin. She's on a high dose of trazodone. And she's on high dose of zolpidem. So there's a lot of kind of polypharmacy issues that are going on. Discharge summary. So they decided she had an opioid overdose, probably due to benzodiazepine combination. And the plan was for the caregiver to provide her medications for her. Continue Percocet as needed, continue clonazepam as needed, and continue all other home meds. So this is the problem. This patient is demented. She's not going to remember by tomorrow what the instructions were and that the caregiver is supposed to give her the medications. She's very likely to still refuse to do that. They didn't change the regimen at all and continued the med list, and it's likely that this med list actually contributed to her overdose. So what should have happened? This patient was not taking any topical medications. It would be helpful to introduce something topical, either lidocaine 4%, Voltaren gel. Her kidney function was actually decent. She could have used an oral NSAID as part of that treatment. If she's still depressed on high-dose escitalopram, that needs to be discontinued and something else needs to be started. So you would cross-taper escitalopram and start either something like mirtazapine, because clearly she's having trouble sleeping. She's on trazodone and Ambien. Or you could start duloxetine if pain is more significant. But based on that pain med, she didn't seem to be taking a lot of it. So, or it wasn't prescribed at a high dose. So maybe she wasn't in that much pain. So maybe the primary thing is insomnia and you would go with mirtazapine. You would definitely stop clonazepam because it's a long-acting benzo and she's demented. That can make her more confused. For insomnia, again, if you're starting with mirtazapine, you could take care of the insomnia and depression with one drug. If 150 milligrams of trazodone is not effective, you should stop it because that's kind of the max dose. And if it's not working, just discontinue it. Melatonin might be an option for someone like that. But again, if you're starting mirtazapine, maybe hold off on the melatonin until you see if mirtazapine is effective. And 10 milligrams of zolpidem for a 70-something-year-old woman is definitely too much. Puts her at risk for falling, more confusion, and not a good idea. For pruritus, hydroxyzine is not a good option long-term. Again, it's anticholinergic. If she has a lot of itching, maybe Zyrtec is a good option. Zyrtec actually works really well for itching, so that would be something to consider. So we're making progress. Adjuvants are being used more wisely. You do want to, when you're dealing with an older patient, you do want to start low and increase gradually to make sure they don't develop more side effects as you go up on the dose. You want to minimize adjuvants that are poorly tolerated in older patients. You want to use that opioid calculator to make sure you're staying under the 50 morphine equivalent mark. You do want to set up a framework for your opioid prescribing with your patients, and review risks and benefits, provide patient education. That's really critical to make sure that patients use it safely, and use the team approach if you're able to collaborate with other healthcare professionals, because I think it'll reduce your level of stress and the patient's level of stress about using these medications. Thank you.